Now we're recording. So, good evening, everybody. Thank you for joining me. So, obviously, these are interesting times, and I want to try to kind of digest some of the information and share what I've learned over the past few days. So, I'm going to temporarily mute y'all, and then, kind of when I'm done, kind of giving the intro, then I'll open up to any questions and such. So if you have me wait just a couple minutes, and then, like I said, I'll open it back up, and you can ask whatever questions. So honestly, I'll be honest, is that 2 weeks ago, I was very much underestimating this COVID-19 SARS-2 virus. I thought it was going to be a very bad kind of flu type of epidemic for people. And even with a math background and understanding exponential numbers, I really wasn't forecasting how intense this could get as quick as it could get intense. But that's the issue with exponential growth. So the first thing I want to talk about is that, it is not time to panic. This is a serious issue that can be dealt with. For the greatest majority of people, things are going to be okay. But there's some stuff that people need to do to kind of optimize their health during these times. And I don't yet know how long this is going to last. I think the most seriousness is going to be felt in the next 2 weeks if everybody kind of optimizes their social distance and really limits their going out. The rate of spread of this virus will really cut down, and that will stop what's probably the number one concern in my mind is overcrowding the ICUs. Because the great majority of people that get this virus are going to recover. Well over 80% of people have a mild version of this. As people who have a severe version of ARDS, which is a severe infection of the lungs, those are the people that we need to save the ICUs and the hospitals for. So to back up a little bit, the history is that, obviously this virus is a novel virus that, humankind has not ever been exposed to. And it is coming out of China, where a lot of the pandemic viruses sometimes start in a animal population. It looks like this is probably a zoonotic infection from bats, meaning that this was a virus that's been in the bat population for unknown time. I saw a video the other night that there's maybe 1.5 million viruses in animals right now that humans have not ever been exposed to. And coronavirus itself has been around for millions of years, and humans have had multiple bouts of coronavirus. A lot of the common colds are coronavirus, so you've been exposed to it. But this is a novel one that acts in a different way, and it's gaining system to the lungs in a different way than the traditional coronavirus. And because nobody's ever been exposed to it, nobody has antibodies to it, so nobody's ready to have the immune system go out and attack it right off the bat. So the longer we can kind of delay people catching this virus, the better we have of really preventing a lot more deaths. So it starts in China. Is the data in China accurate? It's more accurate than people estimate, probably. The Chinese were very forthcoming ultimately with what was going on there, but the number still may be underestimated there. So, obviously China has 1 billion people and they only have less than 100,000 infections. It may be more than that. It doesn't truly matter at this point. I think for the U.S., it's more important to look at what's going on in Italy, because we're very much tracking what Italy is doing, and where Italy is as of 2 weeks ago. So just looking at the numbers right before I logged on, and it looks like St. Louis is up to 6 cases, or I should say Missouri is up to 6 cases, and now the U.S. is over 4,000 cases. And the issue is that if this virus keeps spreading the way it's expected to spread, and we'll talk about how the virus spreads in a moment, there's data that by the 18th, there may be 10,000 cases of people infected in the US. By the 26th of March, 100,000, and by April 4th, 1 million. So that's how exponential growth happens. It's going, and then it hockey sticks up. And the issue is once we hit about 1 million infections, if that truly happens, and to say, the China data is that there's 13.8% of people got severely ill requiring hospitalization. Okay, there's 138,000 people coming to the hospital very sick. Obviously, the hospitals have other things they're taking care of, patients with heart attacks, heart failure, cancer, trauma. The hospitals aren't completely empty. Right now, there's 924,107 regular hospital beds. and there's less than 100,000 ICU beds. And so only maybe 5 to 10% of the people who are showing up in the hospital sick end up being critically ill and going to the ICU. There are not going to be, enough ventilators ultimately if the growth rate keeps going unchecked. There's best guess about 170,000 ventilators in the U.S. And there's 329 million U.S. people, and it may be that up to 40 to 70% of Americans will ultimately be infected with this virus. The key is that not everybody get infected in the next 2 to 4 weeks. If they can spread it out over the next few months and have a slower drip rate of people sick showing up at the hospital, it may not overwhelm the ICU care, because that's literally the biggest risk to the system right now. Yes, there's huge economic implications of what's going on in the stock markets, just the kind of the fear gauge, people don't deal with uncertainty well, so they sometimes will panic. And the economy stuff will, bounce back ultimately, but right now they kind of really got to deal with this, medical crisis. And, my virology and epidemiology stuff, I basically had to do a crash course over the past, 72 hours to reteach myself stuff I had forgotten since medical school. But there's kind of two major numbers that people need to be aware of. There's something on the news that keep talking about the R naught or the R0. That's essentially the number of how infectious this virus is. So traditional flu is about 1.3, meaning that if you have flu, you could potentially infect 1.3 other people. Right now, the COVID virus is likely around 2.2. I've seen some reports up to 4. So for every sick person, they could infect 4 other people. And the one novel thing about this is that there are many asymptomatic people or people with very mild symptoms who don't necessarily, present traditionally that they're going to be going on to progress to severe versions of this disorder. And they may not know that they're infected, and they could pass it off to somebody who is susceptible. And right now, the people who are most susceptible are the elderly. People over 80 have a very dismal survival rate with this, especially people with chronic medical conditions. But the rate, once you're over 60, the rate really starts increasing. So the younger people may not necessarily get sick and die, but they could easily carry the virus and pass it on to the more sick population. So that's why the social distancing is so important, is that the longer we can wait to spread it, the less people are going to get sick right away. But back to kind of the R naught. So I, was, like I said, doing a deep dive in the past couple of days, and I was digging out through some of the numbers that, some of the previous infections. So when the original SARS came out, the severe avian respiratory flu in 2003, the R naught was 3. So one person infected tended to infect 3 people. MERS, which is also their very recent coronavirus, its R naught was 0.8. So meaning that, less than one person would get infected from a sick person, but it had an extremely high mortality rate, which we'll get to in just a moment. So MERS and SARS were much more a problem for the hospital. So if a sick person with those diseases had it, they were so sick that they ended up in the hospital. They didn't have a chance to pass it off to anybody else. And then they ended up infecting a lot of the hospital workers. So the outbreaks were mainly in the hospital. But this current virus is much more virulent, and that it can escape detection for longer periods of time because people are asymptomatic. Previously, if you had MERS or SARS, you knew you had it. You were sick as snot. And it's the same way with Ebola. Ebola was 1.9, but people were so sick with Ebola, they did not infect other people other than the people who were directly taking care of them. And then for everybody who was, I don't have the chickenpox one per se, but the smallpox was 4.8. And then the highly contagious one is measles, so 15. So one person sick, 15 people get measles. So that's why measles just wipes out high schools and colleges for people who are not vaccinated. But measles does not have a high, I don't like using the word kill rate, but it's the case fatality rate, or CFR, you'll see mentioned. Measles, 0.2% of people who get measles die from measles. 50% of people who got Ebola died of Ebola. It wasn't common that it would spread, but if you got it, you were in the world of hurt. MERS was 34.4%, and the previous SARS was 9.6%. Right now, the CFR for COVID SARS-2 is somewhere in the ballpark of, it depends on, whose data you're truly looking at, but it's a couple percentage. It's maybe 2.3%. And these numbers, may go up to like 5%. I've seen some case reports for the Italy, and Italy is even higher. But you got to think about the case fatality rate as something that it's going to be high until more people are tested, because there's a lot of people that have not been tested, and so you're only getting the sick people measured. If you get a bunch of people who don't turn out to be all that sick and not that many people die from it, the case fatality rate will go down. So it's sort of a worst case scenario that you'll see right now. But again, to give you some examples, of a recent bad flu season was the 2017-2018 season. 61,999 people died in the US, but 44.8 million people got it. And there's about 800,000 people got hospitalized that year. So 1.8% people get hospitalized, over 60,000 deaths. This is something that probably 14% or so of people are going to get sick and get hospitalized with. So it's a much bigger factor. Another most recent one was the MERS. MERS, there was only 2,400 cases worldwide, but 850 of those people died. So it had a very high kill rate, but not many people got it because it died out so fast. And then the most recent swine flu, H1N1 in 2009, over 60 million people contracted it, 274,000 people showed up in the hospital, over 12,000 people died from it. So that's kind of the numbers game, and so it's all about the quote flattening the curve, and that's the the idea that the more we can isolate ourselves currently, the more time we have for this virus to kind of burn out its way. It is not yet known from the readings I've done that if you've had this virus, will you be completely immune, or will it be something where you could get it reinfected, but it would be a much milder case because you'd have antibodies to it. It's not known yet. It's not known if the virus is going to completely burn out in the summertime, with like usual seasonal flu tends to burn out in the spring and summer. The one thought is that it's higher UV light that time of year. People start building up their immune systems more. Their vitamin D levels go up, which is a marker of how well their immune system is working, and they're able to clear the flu easier in the summertime. But it's possible that this virus is going to be high, go down a little bit in the summertime, and hang around low, and then might start coming back in the fall and winter. That is a big risk of this virus right now. It is still too soon to know. That's why buying time is the best measure. As for some of the treatment options I've seen, once you're in the hospital, I guess you back up. 80% of people are going to have mild symptoms: fevers, dry cough, maybe some myalgias or muscle pains. There can be some GI side effects. And those people can stay home and recover. They take some Tylenol, Motrin, NSAID, something like that for the fevers, and just stay well hydrated, and things will pass. Take up to 2 weeks is kind of the long end of the symptoms for this. Most time I think it's 4, 5, 6, 7 days. Those people will recover, and they actually may be one of the best sources of treatment going forward. It's called convalescent serum. They can take the antibodies from somebody who's recovered from this virus, and right now it looks like in the US only 1% of people have had the virus in order to fully recovered from it. But they will be able to do potentially apheresis or plasmapheresis, where they'll take the antibodies out of somebody who's recovered. And the data I saw is that essentially for somebody who's recovered, they would have to take that serum and they could treat somebody who's severely sick in the ICU with it. So it's a 1-to-1 transfer. There's also the option that if somebody who's recovered, they could take some of the serum, split it up into maybe 20 samples, and they could provide that to the first line, people on the battle lines of this, the first responders, the nurses, the doctors in the ER and the ICU. And it's basically, something that can prime their immune system so they're not getting as sick. That was one of the things that, were the people who are younger who are having a bigger problem, or a lot of times the medical providers in China. One of the thoughts, reason why, is that maybe it's the high viral load that these people are exposed to. They're constantly getting exposed to the virus, and they build up really high titers. I shouldn't say titers, but high viral loads, and there's just more cells getting destroyed by the high virus loads. So this is why social distancing works. Yes, you may still be infected, but if you don't keep getting it from multiple people, the less bad it's probably going to be for you. Um, then, excuse me, the what to do about it once you're in the hospital, or why should you go to the hospital? You know, honestly, the hospital should be about the last place you ever want to go right now. It's like Willie Sutton says, why do you rob banks? Because that's where the money's at. Hospitals are going to be where COVID-19 is at, or the coronavirus is going to be at, because the sickest people are going to show up there. So if you're not that sick, meaning you're not having trouble breathing, you're not having bad discomfort in your chest, you're not dizzy, passing out, you want to stay home as much as possible and just ride this thing out. It'd probably be a mild cold for you, and something, just because it's COVID doesn't mean you need to absolutely rush to the hospital. Because all that's going to happen is if you go to the hospital or somewhere and get tested and you're positive and you're not bad enough, they're going to send you right back home and say, wait it out. And if you don't have it and now you show up to the hospital, you're potentially going to expose yourself to everybody sitting in the ER and everywhere else who thinks they have it. There's a good chance some more of those people are actually going to have it, and you're more likely to get a second infection on top of whatever you had that brought you there in the first place. So it's going to be an individual call, when you got to decide to go to the hospital. But the number one thing is that if you're short of breath, that's the time you need to make the call and show up. And I saw some silly internet meme, like hold your breath, and how long you hold your breath is determine it. If you're short of breath or not. That doesn't work. It's if you're walking across the room and you can't catch your breath, and normally you're an athlete or you're doing whatever you want to do, that's when you need to go. If you're somebody who's already chronically short of breath, you're likely at higher risk. It's going to be somewhat of a harder call to say, hey, go in. But if you are feeling bad enough to go in and get tested then. But the data I'm seeing that like once you end up on the vent, the data is not so hot. Many people are ending up on the vent for 4 weeks. And if somebody's on the vent for 4 weeks, that's a time that somebody else can't get on that vent. There's only 170,000 ventilators. Once they're full, there's some ways they can sometimes split them. They can kind of make 2 people working on 1 ventilator, but that gets more complicated. Essentially, what's happening with this virus is very, very different from traditional flu. So traditional flu affects the system. Your immune system turns on, fights the virus. And many times it's the cytokines and other things that the immune system turns on to fight the virus that you're sort of having an effect with. That's why the fevers go up, you have muscle aches, nausea, diarrhea, and such. Your body's reaction to the virus. The COVID-19 / coronavirus works in a different mechanism. And this is one of the reasons why heart patients, potentially might be at higher risk. For the technically inclined, this was a flashback to medical school, is that the coronavirus, the current coronavirus, I should say, is a RNA, is a reverse. I'm gonna mess up the word right now, but it's very similar to the way HIV attacks the body. It's an RNA virus. It can't live on its own. So the virus's job is basically to get attached to some cell, get their genetic material into the cell, and use the machinery of the cell to replicate for them, make more copies of the virus. And then the cell pops and dies, and the virus goes out, tries to find more cells to replicate. But the way that this virus enters, or at least the way it's highly suspected it enters the ACE-II receptor. Don't worry so much about what the ACE-II receptor is, but the ACE-II receptor is on the lung cells. There's also ones in the heart. There's also ones in the gut. But the main way it's getting through is probably through the lung ones. Once it gets through that ACE-II receptor, it's attacking something called the type 2 pneumocyte. The type 2 pneumocyte is a type of cell that releases something called surfactant. Surfactant is a soapy-like substance. It's basically something that helps the small airways in the lungs stay open. So if you think of the small airways in the lungs as like little bubbles or beach balls, they're villi, they need high surface tension to stay open. That surfactant coats the inside of them to stay open. So it's kind of like soap bubbles, they kind of glom together and you see them all open. But then, if you pour, grease and other things on, soap bubbles, you see how the bubbles pop and they convalesce. That's essentially what happens when surfactant is not present, those small airways collapse. And when enough of those small airways collapse, you can't gas exchange. So you can be breathing in oxygen. There's nowhere for that oxygen to go into the system, blood go by it and put the oxygen into the blood. So you're essentially almost drowning in all your own fluids when this happens. So these patients in the ICU are extremely sick with something called ARDS, acute respiratory distress syndrome. ICUs know how to manage this, but it's very, very high mortality rate. There is not yet things that they can do other than leave you on the vent and try to hopefully get you through it. Um, you know, there are certain, I'll get into a second, but if they can't oxygenate you, there is a device called ECMO. ECMO is invasive, where you have a bunch of different catheters in your veins and arteries of your leg, and it's basically full-on bypass for you. So pull all your blood out, puts it through a machine, oxygenates it, puts it back in your system. People who go on ECMO are extremely sick. ECMO is stuff that, from a cardiologist standpoint, is stuff you see when somebody is about to go on a heart transplant whose heart is extremely horrific and is failing, and there's no medicines or mechanical pumps that are getting it to work. So you basically have to take over every work of the heart and lungs at the same time. And those people, if they don't get a heart transplant or an LVAD device, they're not going to make it. There's only so many ECMO machines in the US. I don't honestly know how many numbers there are, but they're not easy to use. You need a perfusionist who sits there and watches and makes sure the machine doesn't clot. You need highly skilled ICU nurses to be able to monitor it. ECMO patients are one-on-one. It's one nurse, one patient. The nurse can't have two patients bounce around. The ECMO person is the sickest of the sick in a cardiovascular ICU. So, ECMO, can potentially save people, but this gets into the ethical issues that no physician or healthcare provider ever wants to make. Who is going to end up on ECMO? I honestly don't know how they're going to make the decisions. They're going to make it based off of, how functioning you probably were coming into the ICU. So if you're a younger person who did not have a bunch of comorbidities or problems, you're probably a better candidate for ECMO. If you're 80 years old with COPD and a weak heart, putting you on ECMO is probably not going to get you through this. So they're going to have to make these very hard decisions coming up soon. There are no particular antivirals yet that fully work for this. They're trying to repurpose one that's used for Ebola, might work a little bit. Chloroquine, which is a malaria medication, might prevent somewhat the transmission of the virus into certain cells. Might is the key word. And they're actively working on multiple different vaccines. There is vaccines that they had worked on for the original SARS, which they may be able to repurpose and might have a vaccine come out much sooner than normal. But mostly it's supportive care and trying to get them oxygenated and get them off the vent when they can. Transition a little bit into, what you can do. Start back at the beginning. Don't panic. High stress is going to be a problem for your immune system. So, meditation, yoga, talking to your families, all the stuff I usually talk to you about in the office about how to deal with your stress, that's going to be paramount this time. So work on your stress levels. Focus on your sleep. Sleep is when your body repairs itself. You need sleep to repair your mitochondria. Mitochondria make energy for your cells. You need your immune system to be working optimally at this time. For the people that are going to catch this virus, the better you sleep, the better your immune system works, the better you can kind of knock down this virus. I'm not going to tell you exactly what foods to eat, but obviously eat healthier foods this time of the year, more fruits, veggies, clean proteins, clean fats. Try to avoid the junk right now. And definitely, as for alcohol, honestly, I think alcohol should be the least of your concerns right now. Not a teetotaler by any means for those who know me. But alcohol just is going to put more stress on your system right now, and you need your body at full capacity. So focus on sleep, rest, stress recovery, putting optimal nutrition in, and forgo the alcohol for now. If it's truly into the world type of times, I'll come back on here and tell you let's all do what we need to do. But right now, limit the alcohol. And then as for exercise, if you're already routinely exercising, keep doing what you're doing. But this is probably not the time to be hardcore training for a triathlon or marathon or something like that and putting undue stress on your body. So dial back your training a little bit, but stay active. And as for the question of going to the gym, honestly, at this point, I think it's probably riskier than than it needs to be. The data is just coming out so much that everything that everybody does in the next 2 weeks is going to make the biggest difference. And unfortunately, it's going to be like a Band-Aid getting ripped off real fast. It's going to hurt, but it's better to do it right now than wait a week to do something, wait a week to do something, and then realize that we're behind the eight ball, even worse than we were going to be. So, this, obviously the schools are closing on Wednesday in St. Louis. Some of the stuff is going to be, I'm saying that's fact. My speculation is that it will not be far before the restaurants in Missouri are closed. The restaurants will close. They still probably will do delivery or pickup, but I don't know for exactly how long that may last. I imagine, I'm saying, this is my speculation. Hospitals will stay open. Grocery stores will stay open. Probably some are already starting to come back, so there may be some more limited hours. Pharmacies will stay open. And then everything else is going to be very much up in the air how long they're going to leave things open. I saw right before I logged on here, there's 7 million people in San Francisco. They're basically, it's not martial law there, but they basically say, like, please do not leave your house for the next 15 days unless it's an absolute critical emergency that you need to leave your house. France is doing the same thing. So, it's not to scare everybody or anything like that, but the more that you can be in control of your situation, the better. So prepare before it's, the last second you got to like, oh, I got to go get, blank. Yeah. I still don't quite understand why everybody needs like, 10-year supply of toilet paper. This is not going to last 10 years. The most critical things are have, a good source of water. I don't imagine that sorry about that. I'm not, expecting the traditional water supply to go down, but if you have some bottled water or, I have spring water, stockpiled here, so I'm pretty good for a while with my water. My wife had to go into work today. I went into work a little bit, but was doing more telemedicine. We'll talk about that in a second. But I did make one more run through the grocery store. It wasn't, Armageddon by any means, but, it's reminding me of the old supermarket sweep show, where they're running through there and people are storing everything in their carts, and they're like, oh, he's going for the hams. Well, I'm have a little bit different perspective. So I was going down the aisle that had all the sardines and oysters and crab meat and salmon and tuna. So I have like more omega-3s in my cart than should be legally required to eat properly. But it's not too late to go get a little bit more canned foods and focus on the omega-3s and stuff that's going to be shelf stable, and maybe get a treat here or there. But definitely, if you're going to go stockpile stuff, get stuff that you're actually going to eat when this event is over, because this event is not going to last forever. So don't buy a bunch of food that you're not normally going to eat. I actually have, I'm wearing my Navy hat tonight, but when I was in the Navy, they somehow tasked me being the head of a disaster team, and I had no training initially. I had a gas mask and some kind of go bag under my desk at work. But then they also gave us, cases of MREs, meals ready to eat that, they're barely edible food, but they last forever, literally, I think ever. So they have a shelf life of like 3 years or something like that way. I still have them, they're 10 years old. I'm still not expecting to have to bust into these things, but but food is important, but mostly stay hydrated, stay rested. Those are more important than even the food. What am I personally going to do? I'm going to have very limited excursions outside my home. I live across the street from a park. I'll probably go over to the park, get some sun during the day, but I'm not going to change up things dramatically. It's, do the things that got you to be healthy, or the things that to get you to be healthy. So, my traditional day is I get up, around 5, meditate in the morning, which always helps with, putting your mind in the right mindset to how to focus on the day. I wear my blue blockers in the morning. I see the sunrise. I eat breakfast. Usually right now it's a protein berry smoothie. Weekend it was eggs, casserole. I drink my gallon of spring water a day. I exercise. And then, I do whatever work I'm supposed to be doing that day. And then in the evening time, wear my darker glasses. I have you can see in the background, I got my red light on for now. And then try to wind down at night, and then go to sleep at a reasonable hour. Time restricted eating, I'm sure I mostly do it. So I ate dinner before I got on this call, so I usually finish dinner 3 to 4 hours before I go to bed. And then, rinse and repeat. So it's honestly, my routine isn't going to get that much different other than, the work component of it. I'm voluntarily going to convert. I'm just flat out put out, today is probably the last day I'm going to be physically in the office for a while. So when I started this practice of cardiology in August, I set it out to be, extremely convenient for the patient, and make it an experience that, patients could be treated wherever they're at in the world, and I could be wherever at in the world. So I built out the platform. It already works. It's already been tested. I did another telemedicine visit today with somebody from Kansas City. So we basically would use this exact same platform, Zoom. I can show you your labs. We can, pull up any type of imaging that you had. I'm recording this video. Usually I can record your office visit as well and send it to you, or you can record it on your end and watch it later if you like to. So going forward until the foreseeable future, if you already have an appointment scheduled with me in my office, Cassidy will be reaching out to you and we'll be converting you over to a telemedicine visit if that seems reasonable to you. If you need to wait, for a little bit longer, that's completely fine, totally understandable. But for now, just for everybody's sake, the less we're exposed to each other, the better. So I'm going to lead by example on this and convert this into a telemedicine practice. There'll be a time and place where we'll get back together physically and meet you in the office and such. But the goal is that if you're not sick, you don't need to be coming out to an office and being potentially exposed to other people. Obviously, my new office is in a traditional medical setting, but there's other people there that I can't control, who they let come in who might be sick that day. So it's just better that people don't come into the office at that point. We're going to be here for you no matter what. You have, many of you have my cell phone number, or you at least have our office number, which you can text. You can always get a hold of me or Cassidy, and we'll make sure you guys get through these, next couple of weeks and such. One thing that I said I didn't say too much about was that, heart patients, yes, are at more risk for this, potentially because of, the way that the virus gets into the system. This ACE-II receptor is also present in the heart. And, the data out of China shows that, still half the people who pass away from this virus, it's fully because their lungs just completely fail. But about a third of the time, they're actually having severe heart involvement. So the heart gets myocarditis, an infection of the heart stops working effectively, and then they have abnormal heart rhythms and pass away from the heart rhythm issue. So they will do certain blood markers on people coming into the ICU, and if their troponin is elevated, that means there's significant heart damage going on. Does not mean they're necessarily having a heart attack. But if it has cardiac involvement, it's extremely bad. It's likely lights out. You're probably not going to survive it if it infects your heart. So, people who have heart issues to begin with are just more prone to it because they may have more of these ACE-II receptors on the heart, and they're just more sites that the virus can attach to. So one thing that I was reading a couple of days ago was all about the ACE inhibitors and the ARB blood pressure medications. There were some initial thoughts from the original SARS that patients who would be on an angiotensin receptor blocker like losartan might have had a survival benefit because they thought it might block the receptor where the virus could attach. But now the data is looking like it's 180 degrees. It does not yet look that if you're on an ARB or an ACE inhibitor that it is increasing the risk. So they do not have the data in the US that patients who are on these medicines should stop them or be transitioned to a different medication. So the goal is if your blood pressure is controlled with these medications, just stay the course for now. Don't make any big changes in your medications. If you ultimately want to come off these medications, do it when the virus is not as active. So don't worry about, if you're on an ACE inhibitor or ARB that much. If the data changes, then I'll put out a message on the email or say, okay, the data is overwhelming that we should be changing people. We'll make that decision once we see more data from more reputable sources. If anybody is running low on any of the prescription medications, we can digitally send this into any pharmacy you want in the world. So, I don't know for sure, how long this thing's going to last for, but it is reasonable to have a 3-month supply of any of your mission critical medications on hand. So if you're running low on things, just send us a message through our portal, call our office, let us know what you need, and we'll take care of it for you. But I think that's enough of the numbers and my plan for what we're going to do going forward. So at this point, I thank you guys for your attention, and then I'm going to open it up to Q&A, and I'll stay on as long as needed. So I'm not going to unmute you all at once because it might be a pandemonium, but I will set it so that you guys can unmute yourselves. So on the bottom left of your screen, there's a little microphone. If you click on it, as you see it turning green, that means you're live. So, I hear somebody, microphone open, so whoever would like to ask a question could ask the first question. And Cassie, excuse me, and if Cassie, if you're on here, start just notating what questions are getting asked. So thank you.
Thank you. I'm on it, thanks.
Thank you. And
I have a question.
yes.
If I start running a fever and get sick, what do you recommend that I take?
And fever is the number one thing that people are experiencing with this. You know, Tylenol or one of the non-steroidals, Motrin or Aleve. Those are the kind of, you probably cycle back and forth between those two.
You said Motrin and Aleve? And
Those are kind of the preferred non-steroidals, and then Tylenol.
Tylenol. Okay, thank you.
Sure. Let's see. There's a question in the chat. If sick and stay home, how soon after symptoms stop is it safe to go out? That's a really good question. I don't have a firm answer on it. You know, the test kits are just now really rolling out. And, you know, if you're sick in the hospital, you have to have essentially 2 negative tests before they consider you not infectious. I don't know the exact details on what they're going to say, but that's the one reason that like the quarantine's 14 days. So if you start showing symptoms, it's going to last in you about a week. They probably want you to be about another week before they fully feel that you're not still transmitting. And I kind of roll into it a little bit, is that, you know, the modes of transmission are, you know, known to be droplets. So that's usually like 5 microns. So like, you know, when you cough, you know, it's kind of bigger. When you sneeze, it's really fine mist. That's more aerosol. Definitely droplets, possibly aerosol. And when something's aerosolized, it sticks around longer in the air, but it also can stick longer on surfaces. So there's an article that came on the New England Journal on Friday that, I don't remember all the details, but on plastic, the virus was staying up to about 72 hours. On metals, it was like a day, and like copper was like 8 hours. So the virus is living outside the body longer than is typical for most viruses. And then I'd seen in some data sets, it was in China, that a lot of people were presenting atypically. They weren't showing up necessarily with the fevers and the cough. They were showing up with abdominal discomfort. And initially they were getting thought that they had gallbladder issues or appendicitis, and they got put in the surgical wards in China. And they weren't really monitored as closely, but they were actually, you know, corona patients, and they were infecting a lot of people. And eventually they realized those are corona patients and they isolated them. But they think that was one of the issues with the healthcare providers over there getting sick and dying, was that the doctors were getting exposed repeatedly to multiple people with this, and their viral loads were really high. So it is not 100% clear yet that does this not pass by a fecal oral route. So that's kind of like food poisoning or Norwalk. So possibly, and this is completely conjecture at this point, is that, you know, the Diamond Princess, the cruise ship that had 700 people get corona, that went through that boat really, really quick. Could have been aerosolized for sure, but it might be that if it's a fecal oral route, that stuff always transmits very quickly. So until, you know, we can wait it out next week or two until they can figure out how it's transmitted, it's best just to stay away from people for probably about 2 weeks if you have symptoms. Let's see, lots of questions coming in. Is using an oximeter at home a good indicator of when to go to the hospital? Might be. I mean, you know, if your oxygen levels are getting into the low 90s and you're having some issues with taking a deep breath or feeling like you can breathe okay, then yeah, that's probably a marker that it's time to go get checked out. Question, isn't a fever helpful for fighting it? How high before you take Tylenol? Yes, I mean, you know, the fever is a marker that your immune system's kicked in and it's trying to clear the virus. You know, how high before you take Tylenol? I mean, it's most people are having like 104 fevers with this. So it's like a no joke. It's not like, oh, I'm a little bit, you know, febrile with this. under 4, you usually feel really, really bad. So, use your own judgment. Once you're consistently over 100, you might start considering it to kind of cool it down a little bit. Have I heard anything definitive about getting test kits from drive-in locations? I had not had a chance from noon to logging on to see as anybody else in St. Louis other than Mercy Virtual out in Clarkson and 40 have an actual drive-through location fully ready to go. But you have to still call ahead to Mercy before showing up. They want to kind of go through the story and, do you have fevers or you're coughing? Like, have you traveled to somewhere that has known corona? Have you been in contact with sick people? Like, so you're more likely to have it. Still, people who have fevers and cough, it's still more plausible that they have flu right now for this week, but they'll want to know some of the symptoms before you drive up and show up there. But Mercy Virtual is the only place I currently know that has a drive-in location. Question. Research says flu shots may cause hyperreaction. They don't know yet, correct? Don't know exactly if you're indicating that if you get the flu shot, you're more prone to getting corona. I don't think that's necessarily playing out. But if your body's busy making antibodies towards the flu, yes, your immune system is sort of busy. So I don't know the data right now, honestly, off the top of my head, but I would not imagine it'd be a great time for you to go out and get a flu shot if you've not already gotten a flu shot. What do I think of immune boosting supplements like elderberry syrup or mushroom blends? I heard a rumor they could be counterproductive because of the cytokine response. Could you comment on that? Yes, possibly. You want your immune system to work appropriately. The things that make your immune system work appropriately is the light that enters your, I should say more, it's your skin. So you have your T regulator cells programmed from the light that hits your skin. So this is the reason why, you listen to Jack Cruz or you start listening to me about skin in the game, going outside and getting enough sun on your skin to turn on your immune system. You can't do this by sitting inside 90% of the time. You cannot do this by popping pills and making your immune system work effectively. You need the sunlight to program the cells so they know what to do. And you don't want your immune system to be overreactive. Obviously in the United States, there's a huge, huge epidemic of autoimmune conditions. Not saying if you take elderberry or mushroom blends, you're going to give yourself an autoimmune condition, but there's nothing tested on elderberry or mushrooms. So this is, flat out, there's no medical advice that you should be experimenting on yourself at this time. There's no data. Is it likely to cause harm? Not likely, but not known. So I wouldn't be too keen on myself experimenting on stuff that hasn't been proved to take care of this. It's not necessarily shown on this instance, but in the 1918 flu, mostly took out the younger people because they had a hyper response to their immune system. Their cytokines went really high. Their immune system's like, virus, let's kick it, kick its pants. And it basically, the body, was wiping itself out with the high cytokine load. So you want your immune system to work appropriately, get optimal sleep, work on your stress, and eat some clean foods. Your immune system is supposed to do what it's supposed to do. If current vitals are all good, 5 bypass surgery 3 years ago, am I at high risk? Any additional precautions takes? Yes, you still are high risk if you have cardiovascular disease. So had bypass surgery, stents, high blood pressure, heart failure, valve surgery, anything, you're at high risk. Any additional precautions? It's mostly social isolation is the biggest thing, stay away from other people. And this is where it gets hard to really give people this recommendation, but yes, this means your other loved ones, if you have grandkids, yes, it probably means don't be hanging around your grandkids for the next 3-4 weeks. They may not get sick, but they could pick it up, and they, aren't going to look sick, and you're going to get transmitted from your grandkid. Cautions, the face masks haven't really panned out that well for people for prevention. If you're sick, you start coughing and fevers, that sick person needs to put on the mask so they don't cough out into the environment. But you wearing the mask all the time to prevent it getting in hasn't panned out. One theory is that if you don't know how to wear these masks, you keep jacking and moving the mask, and you start moving and touching your eyes and your mouth, and you can inoculate or infect yourself. But it would not harm you to wear a mask if you had it around public, but it might not be necessarily protecting you. Um, I had atrial fibrillation, heart rate is normal now. Does that put me at higher risk? Um, if you get infected, you're potentially likely to get atrial fibrillation again just because of the inflammation of the system. Can you have tightness in your throat and shortness of breath before the fever with COVID-19? Yes, possibly. Yeah, fever is the number one thing that people present with, but cough is a dry cough is usually the second, and then the shortness of breath is later. And shortness of breath is one of the hardest things because shortness of breath can be so many things. It could be the common cold. It could be flu. It could be, pneumonia from a bacteria. It could be if you have a heart issue. It could be a heart failure exacerbation. It could be, coronary artery disease. So this is why it's challenging at this time. You really got to know your body. If it sounds, the alarm to you that something's off, you got to make that gut call. Should you go to the hospital or not? All right. And then I'm going to read one more, then I'm going to open up back up to a live question. So getting on the daylight, even with that huge cloud cover we've been having, so useful? Yes. Honestly, the more sunlight you can get this time, the better it is. Even if it's cloudy, you're still getting certain wavelengths of light that help. It's going to be most useful when it's UV, when it's UVA, and then UVB, which is midday. The app D-Minder, for those I've told you before, D-Minder is a free app. It'll tell you what time in St. Louis or anywhere you're out in the world, what time to go outside, and UVB radiation hit your skin. UVB radiation hits your skin, turns cholesterol ultimately into vitamin D. Vitamin D is a marker for your immune system. The higher your vitamin D, the better your immune system is going to work for this. All right, so I'm going to pause the kind of the written questions and open it back up to any live questions for a moment. So, does anybody have a question they want to ask live?
Can you hear us?
Yes, I can.
Hi. So I know it's not a primary concern because we're dealing with what we're dealing with, but I've heard different stories about how this was started.
Okay.
Did you get the link we sent you about the high wire? We sent you the researcher, medical investigative researcher guy, Big Tree.
A lot of people have been sending me stuff. So actually, who is this first?
Okay. He was the medical investigative journalist that directed the Doctor Show years ago. And him and his crew left because they couldn't get really controversial information they thought was important to get to the public. They couldn't get it on the network. But anyway, so he started this news report, pretty global audience now. And you go to YouTube, The High Wire, or it's called Inform Action Consent Network .org, ICAN.org. But anyway, they were talking about that this virus is not naturally occurring, that it was created in a lab. And
that is not what has been put forth in the medical journals. So I don't want to get down the path of any conspiracy theories about this at this point. That we can chat about those things at a later time. I want to stay a little bit more clinical. What this virus can do to you, what you can do to keep yourself healthy at this point. So I want to keep it a little bit more clinical tonight.
I understand that. And so you don't advise anyone decreasing their ACE inhibitors until there's a problem?
Not that there's a problem, but if people abruptly stop their ACE inhibitors and have hypertensive rebounds, they can contribute to a stroke, they can contribute to a heart attack. Then you're showing up to a hospital with an acute emergency and hospitals are full and you're exposing yourself to COVID when you're having a heart attack. That is going to be catastrophic. So, the data has not been shown that it's risky enough at this point to be on the medicine or to take it for prophylaxis. Last week, I was thinking, I don't have high blood pressure. I was thinking last week, I'm going to go buy some losartan and start taking it for myself. That data did not pan out. And so following some very credible other physicians and researchers, and even the European guidelines, they're not recommending switching from ACE inhibitors to ARBs at this time. All right. So, and then I know there's another person live. So
I have a question.
Do you have a question? Okay.
When I'm walking outside, even on a cloudy day, and it's cold out, I'm all covered up. I've got a hat on, I've got gloves, I've got a jacket. There's not much skin exposed. Does that still help?
It helps for your hormones that'll help you to go to sleep, but for vitamin D, no. Your skin's a solar panel. You know, it's equivalent that, like, you know, if you had a plant outside and you throw a blue tarp over it, is it going to grow? No. So,
Okay.
so the more skin you can expose, yes, I don't want people out there getting frostbite, but when it warms up enough, you want to expose your arms, your legs, whatever you feel comfortable exposing. And especially use the D-Minder app that'll tell you what time of day to be outside optimally to do that.
Thanks.
You're welcome. All right. So I know there's two other lines that are open. So Diane's open. So Diane, did you have a question?
Yes. Hi, Dr. Twyman. Thank you so much for this encounter. It's quite fascinating and very good. My question is, and me in particular, okay, so if I'm going through some diagnostic tests, I am scheduled to have further tests. These tests are down at Big Barnes.
Okay.
They're not emergency tests, but they, they warrant me getting these tests. Would it be helpful if I even put them off for like 3 weeks or a month?
Yeah, without getting into the nitty-gritty details of whatever the medical condition is, if it's something that can wait, it should wait. In my mind, anything that is elective should be pushed off.
Yeah, no, it's not. It's not elective. It's a diagnostic. So, women will, like with mammograms, so I need repeat studies and blah, blah, blah. So I'll just go ahead and wait. What's another month, right?
Right. Or it's not that it's emergency, but it's one of those things that, that's a decision you got to make with your docs who are prescribing it or telling you to get it. If you can get it like tomorrow, that would be better than waiting until next week to do it, because, with exponential growth,
Yeah,
one,
that's the
next days there's 2, then there's 4, there's 16, it just keeps getting bigger. So, the sooner you can get it done, the better, or wait it out a little bit.
Okay, thank you.
All right, next one up live will be a Jim, if he still has his line open.
Yeah, hi doctor, how are you?
Good.
Good, thanks for the event this evening. It's been helpful and educational. I do have a question going back to the grandchildren thing. You said kind of, stay away from the grandkids. I've got an 18-month-old, just got pulled from daycare because the daycare is closing. I was around her on the weekend. I'm just curious about, the risks of being around her, going forward in the next few weeks.
It's a really tough question, and I have family members who are in the same boat. My mom's watching my nieces and nephews tonight because my brother's a paramedic and my sister-in-law is in the medical space. So I mean, there are people that have to go out to work. So there's going to be exceptions to the rule, but it's one of these that I know everybody wants to see their family right now, but it's just such a it's not like the measles where one person gives it to 15, but one person giving it to 3 or 4 people is still a big deal. And so the kids are not as likely to data, and they don't know why exactly the kids seem to be quote protected from this so much or getting the serious versions of it. But the kids, anybody who's had kids or grandkids know that when they're at daycares and schools, I mean, they're like little germ mongers. They glom onto everything. And it's just more likely that they're going to pass it on to the at-risk population. And so, like, while I'm not sick, I don't want to pass it on to my family members. So I'm not going to be seeing my family members for a while. So it's got to be a family decision. Risk versus benefit. Is it the highest risk? No. But if it's all possible that you just be with who you're normally with, that's the best way to go about it.
All right, thank you.
Sure. So there's a person doing a hand wave on an iPad, Sandy. So let me see if I can. Doesn't say you're muted, so you should be able to chat. If Sandy's still on her iPad and wants to ask a question, she can.
Dr. Twyman, it's Sandy. Can you hear me?
I can.
We actually asked our question earlier in the chat about, we were the one, my husband has some upper airway symptoms and shortness of breath, had been down in Florida, but he doesn't have a fever and he's not coughing.
Sure.
So, but his shortness of breath, he described as like when he was walking the mall and going up and down the stairs. So not like just normal walking with exertion. So we were just kind of puzzled about if we should pursue it or little headachy. I don't know.
Yeah.
But no fever, no fever.
Yeah, it's extremely rare that people would have this and not have fever.
That's what I was thinking.
That's the biggest hallmark. And it's really the line in the sand is the shortness of breath. Like when people feel like they can't breathe, that's when they actually have to go in to get it checked out. If it's something, you feel like you can write it out, everybody's gonna make their own decision on that.
Right.
My level is probably different than others. I know how virulent the bacteria and viruses can be in the hospital. So unless they're going to end up putting me on a ventilator, it's unlikely I'm going to show up to the hospital.
Right, exactly. That's what we've been talking it through. Thank you.
You're welcome. All right. So I'll take one more live and I'll go back to the ring question. So looks like Philip unmuted himself. So.
Hey, Dr. Twyman, thanks again for doing this.
Oh, you're welcome.
I want to ask you about folks being at risk that have high blood pressure and high cholesterol. Can you comment on what is it about this sickness that, that puts you at risk for having, that you have high blood pressure and high cholesterol? What is it about the sickness that makes that such a complication?
It's that it's, hypertension is affecting the renin-angiotensin aldosterone system, the RAS system, and you end up upregulating the ACE receptors on the heart, and then there's just potentially more access points for the virus to get into the system. That's at least their initial theory. Is it everybody with hypertension? I don't know if it can absolutely be a blanket statement. It might just be that, it tends to be older people tend to have more hypertension to begin with. And so they're the higher risk population. So, the extremely high risk people are the elderly with bad lungs, prior smokers, COPD. They're the ones that this is not faring well, especially people over 80. That's the data out of Italy that, the mortality rate's extremely high in that population. 40-year-old, 50-year-old with hypertension, are they high risk? Higher risk than somebody who doesn't have it, but not so high risk that they need to, take extraordinary measures. It's, take your blood pressure medicines, do the things I talk about for stress relief, and socially isolate like everybody else is going to do.
Thank you. Also, I'm on lisinopril. You were talking about ACE inhibitors. I don't know if that is an ACE inhibitor or if there's any concern of being on that drug in particular with this.
Correct. Lisinopril is a type of ACE inhibitor, and that's what I was saying is that the data is not clear enough yet that people should be switching off of the medication. I'm not overly concerned about people being on at this point from enough sources. If the patient themselves are highly concerned about it, we'll take it offline from this and, we'll work on patients trying to switch things. But, it's one of those things that in my mind is do you really want to switch something that's working right now during this and try to take something that's unknown? And then potentially going to the pharmacy and waiting to get your meds and being exposed to all the sick people who are coughing in the pharmacies. So, that's the only thing that the patient can decide, their risk tolerance to this medicine. The data has not been that patients on ACE inhibitors are doing, worse than people who aren't on them. The data just isn't clear enough yet. Yeah, great question. I knew that one was coming up tonight. So, all right, I'm gonna switch it back up to the written questions for a moment. Should I have a platelet injection in my shoulder on April 1st or wait? I don't know if I answered this question before, but if this is a platelet-rich plasma because you have a inflamed shoulder, it's a tough question. It depends on sort of where it's happening at. If it's a private doctor's office, maybe a little less risky. If you have to go into the hospital, I honestly would not go to the hospital unless you have an emergency at this point. If you have a trauma, you have a heart attack, or you cannot breathe, go to the hospital. Everything else in the hospital should be completely put off for a couple weeks if you can. Do I think there could be more cases in St. Louis, but people have not been able to be tested? Yes, I definitely think this is true. Once the test kits get out more effectively and it can be ordered more openly, the number of people who positively have it and the people who have been tested and are negative, those numbers will switch it up and more people are going to pop positive. So the numbers, are going to look bad all of a sudden. We right now, before going live, there's 6 cases in Missouri. There could be, I don't know, there could be a couple hundred cases in Missouri right now, but people haven't been tested. And if it's mild, they may just think they have a regular cold. And so we're not going to know a little bit about the full-on penetrance of this for a little while. But all of a sudden, you're going to see the numbers exponentially creeping up. And like I said earlier in the beginning of this, if things don't change, in 2 days, there's going to be 10,000 cases in the US. And by the 26th of March, there may be 100,000 cases. So it's going to logarithmically keep jacking up unless we hide from people for a while and just take care of ourselves and let this thing kind of die down. The reason that is that, that R naught number of, between 2 and 4 is that, think about how many people you possibly know. So if you go into a room of 100 people, you potentially infect 4 people. That person can infect 4 people. Ultimately, the entire room, everybody's going to have it. So you can't keep infecting 4 people at a certain point. But the less people that you put in the room that are infected, the better. It takes longer for those 100 people all to get infected. And if we can slow down how fast people are getting infected, that will save the ICUs from being overloaded. Yeah. There's a question about, I have a MUGA scan scheduled this week. That's kind of a special type of nuclear medicine test to look at heart function. Should I cancel it? What would you suggest? Ultrasound shows the heart's gone, improving. I don't know for sure. I don't particularly order MUGA tests very frequently. So I would honestly talk to the person who's ordered the test to see what their feelings are for it. My personal opinion is any test that isn't going to make a change in your medications or your long-term plan in the near term should be delayed for a couple of weeks. If it's going to be a mission critical, I need this answer because they're going to change me to this medicine or they're taking me off this medicine, this happens, then risk benefit, probably go get it. All right. All right, so that looks like we're through the written questions for now, and we're about an hour into it. I'm willing to keep going if there's more questions. So, somebody said, to clarify, did you mean extremely high risk or all those over 80 or those over 80 also lung conditions? Think of my parents, age 81. The data at Italy is mainly, it's anybody over the age of 80, but if they have a lung condition or a smoker, it's extremely bad. So that's, the reason why the social isolation thing has to happen with the healthy people, because we're going to likely be exposed. 40 to 70% of Americans are going to be infected at some point. Is kind of the projections. But if we get it and can survive at home for 14 days and it's gone, but that 80-year-old can stay at home and they don't catch it, then it's a win for everybody. And also the goal is if we get enough quote healthy people catch this and then recover, then our plasma can be used as a treatment for that 80-year-old when they get it. If we can delay them getting it till 3 months from now, well, maybe we have a better answer. Maybe one of these antiviral medicines is going to work. Maybe some of the other meds for other conditions that we found potentially work. So trying to delay it. But anybody over the age of 80, my strongest recommendations medically and personally is they should not leave their house unless they have a medical thing that they need to go get checked out. Somebody should be bringing them food. Somebody should be go getting their medicines. They should not leave unless there's an absolute mission critical reason they have to leave their house right now.
Dr. Twyman, this is Sandy. Can I ask another question?
Sure.
So I work in healthcare and I am doing virtual warnings for people that may need testing.
Mhm.
Do you think the CDC guidelines for who needs to be tested are going to change, mainly in regard to travel? Because it's still international travel or areas where they have a lot of transmission, like Seattle or New York. But I think it's well beyond that now. And we have people calling and they really want the test. And I know we have limited tests, but do you think that's going to be relaxing? That you don't have to have had the international travel?
I think
Do you know
that,
what I'm asking?
yes, more people want to be tested. Are they going to let people get tested who want to be tested? I think that answer is yes.
Correct.
And, I saw today, that, both Quest and LabCorp have tests ready to go. Last week there was only 75,000 tests available. Now there's at least 1 million tests available. But, I think right now it's about 4,000 Americans are, quote, infected right now. I think they will still, at least in the short term, meaning the next week, probably still restricted for people who are at highest risk. So people who've been in places, they've been in China, they've been in Italy.
Correct.
Recently. You're right. They're in Seattle, they're in New York, where there's a lot of cases. Those are the people that are most at risk of truly having it. Or you're an ER doctor or nurse, the risk of that if you have it, they need to quarantine you. So they're going to always have those people first. The average, I don't want to call them weekend warriors, but hey, I had the sniffle. I want to know, did I have it? That's not the best use of this test right now, because you put yourself at risk going out to get tested. If you're not sick, don't get tested, because one of two things happens. It's kind of like a square box. You're really, really sick. You get tested. You have it. Okay. Then the decision is you're going to get treated at home. You're going to get treated in the hospital. You're not sick. You show up. You don't have it. Good for you. You don't have it. That doesn't mean you're not going to get it. And did you just expose yourself when you didn't truly need to?
Right.
Or you don't have that many symptoms. You go get tested. You're positive. The answer is go back home, quarantine. So if the answer was you're going to quarantine for 14 days anyway, don't ever go out to get tested unless you're short of breath and it's going to change something.
Okay.
I think the best people to be tested are people that are once they're actually into the hospital system, because then they got to quarantine those people in different parts of the hospital, and they can project. There's different calculators you're using with different labs that when people are coming in to figure out who's the person who's most likely to kind of crump and end up on a ventilator. So every person, myself, I don't plan to get tested at this point. I like to know data, but it's not going to change what I do right now.
Right. Okay. Thank you.
Welcome. Yeah. Interesting thing, Cassie just posted that I guess one of the advanced lab testing companies we use is now doing the testing. So that'll be interesting. But honestly, I don't know why anybody would do an advanced lipid testing and go get tested for COVID at the same time. It's it's going to be something that it's great if they can run it for people, but running it in outpatients isn't going to make the most sense ultimately. Yeah, here's a good question. It's a hard one. I was considering home renovations, which would bring various trade workers into the house, thinking that it might not be the best to proceed for now. Yeah, possibly. Just for their safety as well. I mean, you're likely not sick right now, but do you want somebody who, you don't know what they've been doing? If you've been kind of deep cleaning your house and they're touching your stuff, and this thing lives on the surface for maybe 72 hours, you're gonna have to deep clean your house every time somebody comes into your house that you don't know what their story is. So, in my personal opinion, like I said, I'll let my family members in, but I don't want friends visiting. I don't want, random people in my house right now or my office. I'm going to do everything virtual. I mean, yes, I'm going to go outside. I'm going to go to the park. If you're outside getting natural air and natural sunlight, you're not likely to be, contaminated doing that. I posted on the Facebook group earlier in the week, there's a link I got from Dr. Cruz's site, about the 1918 pandemic, the 1918 Spanish flu. The people who stayed outside, they didn't have enough hospitals at that point, 100-year-old technology. They had a lot of, surgical tents essentially outside. the patients who were outside tended to do better than the people that they kept inside. So, the answer is get outside as much as possible. That's the written questions. I'll go back to a few open ones if people have want to speak live. I know Diane unmuted herself again. Was there another question?
One more question.
Sure.
Do you have a anything in writing of this seminar, or this webcam that you did that can summarize it all and it be emailed or anything? I mean, I'd like to share it with my family members and friends, and just because your knowledge is priceless for us.
Sure. Well, thank you. Honestly, at this point, I don't have anything written up. It's been nonstop reading and videos and taking notes the past couple of days. But I am recording this video, and it's already being streamed live on Facebook. So after this is done, I will take the link and put it up on YouTube so people can share this with whoever they like. And maybe over the next couple of days, we can be able to type up a few of the kind of the questions that people are answering. But, yeah, fairly.
Oh, okay, so there will be a YouTube on this?
Correct. Yeah, I'll have the link to this video that people can watch on YouTube, and they can rewatch it. And I'm mostly posting stuff on Instagram these days. My handle's at Dr. Twyman, Dr. Twyman. That's where I see, follow a lot of credible physicians on the front lines and seeing their stories. And, that's basically, my specialty is that I can kind of interpret what they're doing and can explain what it means in layman's terms.
Perfect. Thank you.
Sure.
Whoop.
Well, how do you do the deep cleaning? Clorox bleach wipes, really wipe things down that, get used. I'm not hardcore enough. Before I got on this one, I was listening to Dr. Cruz's Q&A with his members, which I'm a platinum member with. He was talking about if you can get a UVC light that like ORs use, that would be key. I have no idea exactly how to get one right now, but maybe some people have their ways. Maybe after this, I'll get on Amazon and start trying to see if I can find one. But UVC lights, you need to know what you're doing with this thing. You potentially would hurt yourself if you don't know what you're doing with it. But UVC lights can sanitize things too. But mostly just use Clorox or anything that has over 60% alcohol in it should help clean surfaces. There's a question about me using red light. Yeah, that's what's in the background. I have a EMR tech on the background. It's not just mood lighting, but that's a photobiomodulation device. Red light stimulates the cytochrome 4 in your mitochondria. It makes energy without having to eat food. And the healthier you keep your mitochondria right now, the better your immune system works. So I'll be running this red light pretty much nonstop anytime I'm not outside, which I plan to be outside a lot the next few weeks. But I'm not going to be in big crowds. I'm going to be down the park or out on my balcony and I get as much sunlight as I can. Would UV lights help with vitamin D production if we can't get outside? Good question. Yes, I also have a UVA light going on right now, kind of like a black light. Black lights don't cause you to be tan. It's UVB radiation that causes you to make vitamin D. Again, use the D Minder app to track your vitamin D production. But unless you know what you're doing with the UVB lights, you can definitely injure yourself. So unless you personally have a tanning bed at your home right now, the data is that you should not be going anywhere to try to tan in a bed, because the chances that they could clean that bed clean enough for you right now are about 0. So you don't want to be exposing yourself to somebody who might have COVID, and laying in their virus films and such. So use Mother Nature's disinfectant. Use sunlight. Midday, ballpark 10 a.m. to 2 p.m. is usually pretty good. So, if you're naive to the sun, build yourself up. Go get 10, 15 minutes of it. But again, that D-minder app, you basically tell it how much skin you have exposed, and then also kind of your skin type. If you're a fair Irishman or you're a very dark equator individual, is a different amount of sun you need. If you're extremely dark, you need 5 times as much sun as somebody who's very light.
Mike, this is John. Can you hear me? Mike, can you hear me? This is John.
Okay, I can barely hear you, but yeah, go ahead.
Okay, I'll speak up a little bit more. I have UVA lights, bulbs in about most of my rooms. I keep them on during the daytime, but they shut off at night with timers. And I've heard different things, whether you can use them all day or not, or what, or all night, I mean. What's your suggestion?
Great question. And this is just pass on. I was just listening to Cruz's Q&A before I came onto this one. He said UVA anytime you're indoors right now.
Oh, all night too, huh?
You guys said anytime you're indoors, but personally, I don't know. I think I would not do it when I was sleeping. So yeah.
Okay, thanks.
Sure.
Mm-hmm.
All right. Well, we're about hour 20 into this, so maybe one last question and I'll wrap it up for everybody tonight. I do thank you guys for your attention tonight. I know this is scary times, but with information is power, and we'll get through this together. The number one thing is take care of yourself so you can take care of others. So work on your stress levels. Everybody's gonna have stress this time of year, especially with what's going on. So meditation, yoga, deep breathing exercises. If you're interested in meditation, my sister-in-law does meditation classes. I'll post a link up in the Facebook group later about what she's doing. She's offering some free meditation classes this week if you want to learn about that. But take care of yourself, deal with your sleep, get outside, take care of each other. So, all right. Well, you guys are all very welcome tonight. Thank you for the kind words. And if you need anything from myself or Cassidy, call our office, give us a text. We're going to be there for you, and we'll get all through this together. So you guys have a great night, and we'll be in touch soon.
Thank you.
You're welcome.